Good afternoon and welcome. What we're going to be discussing this afternoon is something that has been a problem during the COVID pandemic in particular, where face-to-face contact with patients has been less easy than has traditionally been the case. And this has been a particular issue in terms of consenting patients for practical procedures. And it's been a concern of a lot of clinicians is how you maintain the integrity of the consent process while minimizing patients' trips to institutions, particularly institutions which can be a fair bit of distance to travel. And particularly for those patients who are potentially more vulnerable, avoiding crowded outpatient and hospital facilities. So what we're going to hear just now is a discussion from Dr. Jonathan Behar and colleagues of how they've managed to achieve this, or at least achieved a pilot of it in London. So Jonathan, over to you.
Fantastic. Well, thank you very much for the introduction, and thank you to the Arrhythmia Academy for supporting this and asking me to do this talk. I'm going to speak about digital consent pathways in cardiology. And of course, while we're talking about cardiology and cardiac procedures today, this is of course applicable to really anyone having a procedure in the way that we disseminate information to our patients so that they understand what it is that we're proposing as treatment for them. So consent, as you know, is of course a process, and in the United Kingdom we have some really useful guidance through the General Medical Council document, which last year was updated and talks quite specifically about the need for patients to understand risks, benefits and alternative treatment options. The most important point that the document last year highlighted was that a dialogue takes place, that this shared decision-making process is indeed a process and not a one-sided event where we barrage patients with a load of information and then get them to sign a piece of paper. The signature does not constitute consent. And indeed, there's 7 different guiding principles of ensuring that patients really do understand what the treatment is being proposed, the benefits, the risks, and specifically the alternatives if they don't want to go ahead. Now, this is particularly important because the current consent process, and at least up until the pandemic for many institutions, including our own, was that we would use paper forms such as this one. They would be performed on the day of procedure. They may call upon short, quite rushed conversations with patients, and there may be a lack of time for patients to actually consider the options as they're often attending for their appointment and getting consented on the day just beforehand. And there really seems to be quite a focus on the signature, the wet ink signature on a piece of paper, which of course does not constitute consent itself. It's just a documentation of the process. Additionally, the paper forms also have potential areas of omission. If we miss out particularly important salient details, writing can be, and usually is, illegible, and it's not particularly standardized. And more recently, there's also been a real shift in focus around consent. And this has been due to a number of different rulings. In the United Kingdom, one particularly important ruling was the Montgomery versus Lanarkshire case of 2015, where a short lady with diabetes delivered a child who suffered shoulder dystocia and unfortunately had cerebral palsy as a result. And she claimed she wasn't informed about the risks linking diabetes, large babies, and small mums. And the UK Supreme Court ruled in her favour, suggesting that patients should be informed of material risk that a reasonable person in that patient's position would regard as significant. And this is absolutely key because up until this point, certainly in the United Kingdom, we used what was called the Bolam test. So what a medical practitioner would think was important information to give to the patient. And this has now really shifted to what the patients or what a patient in that position would feel is important information. And consequently, in the last 5 or 6 years, the amount of money with respect to litigation for NHS hospitals has really skyrocketed. And it's important that we all understand that, therefore, the patient is really central to this process, this shared decision-making process as a consequence. Now, during the pandemic, this presented a number of challenges, and we at the Royal Brompton Hospital in Harefield, where I was working over the last few years, we instituted a digital pre-assessment patient journey that incorporated 3 key digital aspects to try and address both the problems that I've stated at the outset, but also try and address the issues of face-to-face consultations and the challenges supporting this during COVID. So we used 3 tools. We used a video online platform called Attend Anywhere, used by a number of NHS providers. We used animation-assisted consent videos, which I'll come on and show you in a second. And we also used digitization of a consent form that was electronic. And the patients were sent a scheduling letter with HTML links to the Attend Anywhere, the video platform, as well as the animation website, as well as the digital consent. And they had access to all of these ahead of their consultation, ahead of their appointment. And what this really allowed was it enabled and facilitated them to think about the questions they had, hone the questions that they had, and then at their pre-assessment appointment, really go through the specific concerns that they had with the clinical healthcare provider, which in this case was a specialist nurse. This meant that they were effectively ready and consented for their procedure ahead of actually attending the hospital, where they would have their routine bloods, and in this case, COVID test, to ensure that they were okay to go on the day of their procedure. So just to talk you through the animation videos, this was a collaboration between ourselves and the Explain My Procedure group. The website's there on the slide for people to have a look. These are medical animations to support communication, patient understanding, and shared decision making. And it's a digital platform which you can read on any phone, smartphone, or iPad. And there's a choice of languages available which are particularly helpful. And these are being developed by clinicians so that they can be embedded into the entire patient journey from the point of referral. So when you see them in clinic, you could give them the link, or you could put it in your letter when you write to them and their primary care physician to tell them about what's going to happen, all the way through to when they have the procedure. And these videos can be watched time and time again. Patients often like to watch them with their relatives and go through questions, perhaps think of things that they didn't think of during the consultation. That seemed to be a recurrent point to many patients that we spoke to. It also talks through different risks and explains them in layman's terms, talking about the different material risks that patients may have. And patients may, of course, regard these risks in different ways depending on the job that they may do. It may be more relevant for certain professions rather than others. And this is an example of the website that can be created and made for individual hospitals, and one that we subscribe to. You can see that there's a variety of different thumbnails, and we trialed this initially within the Arrhythmia care group, within EP and devices, but very quickly expanded into coronary intervention, TAVI, and cardiac surgery as well. In addition, the electronic consent form that I mentioned earlier was a key part of this. Ensuring that patients had access to this ahead of their consultation meant that they could really look through the finer detail and really understand what was going on. We, of course, tell patients quite a lot of information at the point of consent, and I think it's really important that they are able to see this in bite-sized chunks and actually go through it at their own pace with relatives if required. And effectively what we did was compartmentalize the form into sections. So I think there's 17 or 18 sections in a big consent form, talking through the actual condition, what it entails, what the procedure involves, the potential success rates, the risks, the benefits, the alternatives. And at the end of each of these small sections, we get patients to confirm understanding by clicking yes at the end of each section. And then once all of these sections are completed, they are able to submit the form. And this creates effectively a digital signature by clicking. And then what we do is integrate this form, either a Word or PDF document, in quite a simple manner using Microsoft Teams. And you can see that here. We add the patient with their unique identifier straight to their patient record, as you can see in number 3. And then that becomes a part of their file, part of their electronic health record, so that we have documented evidence that they've had a consultation process, that they've signed the form, but also that those questions have been gone through, and it provides an auditable trail as well, particularly for the governance processes within the hospital, which is important as well. And here's just a summary of some of the patient-reported outcomes, very crude questions to ask them whether they understood the procedure that they were about to have, the benefits of the potential procedure and the risks, and also the alternatives. And you can see we asked 48 patients before, 51 afterwards, and you can see a significant improvement in how patients felt with respect to understanding, which I think speaks for itself. The concerning thing is, of course, actually that only 50% or so of patients beforehand really understood the procedure, the benefits and the risks, and even less the alternatives. So there's still a lot of work to do. So in conclusion, this pathway, this digital pathway delivered during COVID had the ability to empower patients. It improved their experience. It also reduced hospital contacts and infection risk, and this may be important going forward as we move into a post-COVID era, but I suppose that's up for discussion. It did reduce the use of paper postage and travel, which also may be particularly important, and it also supported remote working for staff. Now, this digital approach is quite simple. It's also transferable to other care groups and centres. And so we hope that sharing this information is useful so that others that may be interested in either cardiology or not in cardiology may be able to pick this up and run with it to provide care for their patients. So in summary, the process of seeking consent is changing. It's more patient focused and quite rightly should be. Digital tools and pathways can transform and improve care, and these animations serve as an excellent education resource, not only for patients, but also for clinical staff, for teaching medical students, for example. And e-consent is an efficient and digital approach to document the clinician-patient discussion. And with that, really, I just wanted to acknowledge the whole team who are pictured here on the left, who led this important work with me at the Royal Brompton Hospital, and we're very grateful for listening, and I look forward to speaking to you about it. Thank you.
Yeah, thank you very much, Jonathan. So that's really impressive. So actually during COVID-19, the world turned digital, and you actually show that indeed also e-information, e-consenting, and actually this complete consent process can actually also be, at least in part, digital. What I particularly liked in your presentation is that you were actually able to really integrate digital approaches into already existing consent processes, right? So it's not actually completely different compared to what we did before, but you showed, for example, those movies, those information movies, which might actually add something in addition to what is normally done during those consent procedures. So do you actually think, or better, what component of this e-consenting, e-information process do you think is actually the main part which also results in improvement of the outcomes of the patient-reported outcomes? So what is your feeling there?
Yeah, thank you, Dominik. I think that the main thing actually is not just the information that we provide to patients, because I've seen many different hospitals do it in different ways. I think the timing is absolutely critical. Now, the timing is not digital at all. It's in a digital format, but actually providing the information ahead of the procedure, allowing patients to go through the information at their own pace and then come up with questions and come back to you, allowing that time for consideration. I think that's the key component here, because we often know in the clinic and in the cath lab, when everyone is often rushed, patients don't often feel that they get enough time to really think about what you've said. I mean, let's face it, they probably remember less than 10% of what you actually say. So having tools that are online and digital that they can refer back to again and again ahead of the consultation, upstream of that consultation, upstream of their procedure, I think is the cornerstone of what makes this really transformational. And I think what changed that kind of rate of 50% up to 90% plus.
Jonathan, can I just pick up on that point a little bit? And I have to say, I've seen these videos, and I think the content is extremely impressive. And actually, that I haven't seen anything, in my view, that's quite as good as this in terms of explaining procedures to patients. But if you go through that electronic consent process, the various steps that you describe, and a patient were to get part way through that and actually come to a point where I'm not sure that I understand this, what's the mechanism then for interacting with the patient to be sure that the detail of the consent is gone through? Because that will, I mean, I'm sure it's common experience. Different people worry about different elements of a procedure, and that reassurance or the emphasis over a particular point or particular risk will vary from patient to patient. So how does that work in this process?
Yeah, thank you. That's a great question. So the way that it works is that they obviously have access to the consent form ahead of time so that they can hopefully look through it. But actually part of the pre-assessment appointment is for them to go through that consent form in the different sections with the individual. So they can actually, in effect, sign the consent form if they want to, but what we generally tell them to do is actually wait to go through it with us during that consultation. The idea being that they're able to complete the consent form at the end of that discussion to make sure that they are happy. If they're not happy, however, then we may need another discussion with them, and it may be appropriate for them for that consultation to stop the process, for them to go and speak to a relative and say, well, you know what, I actually didn't quite realize those risks. Actually, those risks are things that really concern me. I don't want to consent at this point. I'd like to put the brakes on this and have a real think about it. Now, I think that's a good thing that we have the opportunity to do that. There isn't a specific mechanism to half consent, because ultimately we want them to go through the form and understand all elements. But I think that there's certain iterations, I should say, as well, of the form ongoing to try and make it slightly better and to add tweaks to it. But I think that the simple process is that if patients are not happy with any elements, then that should put the brakes on, and we should explore the questions with them, and if necessary, come back at a slightly later stage so that they have the chance to go through those things rather than force the signature. They're not happy and then we proceed when we shouldn't.
Perhaps just one follow-up question before Dominik comes back in. And that process, is that always conducted by the operator, or is that the pre-admission clinic consent process, can that be conducted by a member of the wider heart team, by a specialist arrhythmia nurse, for instance?
Yeah, so the process as we set it up was that it was carried out by one of the specialist arrhythmia nurses. So they were highly specialized, very experienced, had training directly in consent and the consent process, and then trained specifically within the procedures that they were consenting for and signed off to do so. I think that, I suppose, in itself leads into another really important point, which is training and who's doing the consent. It, of course, could be the clinician, but certainly in the UK, and I know across Europe and elsewhere, we have, as you said, a wider heart team that encompasses a variety of allied healthcare professionals who are also highly specialist and able to help in the process. So in this scenario, it was a specialist nurse. It doesn't have to be, but it does raise the point that anyone that is consenting is someone who is able to qualified to take the consent and understand and go through the considerations and complications.
Thank you.
So, Jonathan, during your presentation, I also noticed you talked about dialogue. Dialogue is actually something which also is very often based on relationships, on eye contact, on feelings which are actually occurring, right? And I mainly actually mention this because consenting and patient information is not just transferring information, but also should actually give you a space for shared decision-making and other things. So how do you think is this time point this option for shared decision making possible if you mainly use e-information and e-consultation, or is this actually something which happens first and then after shared decision making already happened, you actually use this e-consulting technique?
Yeah, I mean, that's a fantastic question. I think you raise a really important point, because I guess during COVID, we were forced to behave and interact with patients in a different way. And much of that was really positive, and we were able to do things that we probably wouldn't have been able to do had COVID not occurred, and accelerate various digital platforms. But I completely agree with you that we have lost to some extent that human contact, which I think everyone craves and wants to get back to. In terms of an actual solution, I think I personally think there is probably a blended approach between face-to-face medicine and digital and telemedicine that needs to somehow develop and evolve going forward in terms of what the right solution is. And it may be different for different patients, but I would envisage a face-to-face consultation between the healthcare professional who's proposing the treatment, the consultant, cardiologist, for example, initially, because I think it's really important that you get to know your patients and they get to know you, and you have that trust, usually from that human contact. But then I think it probably is appropriate, and I think most patients would support this, maybe not all, but then I think it's appropriate at a later stage in that pathway, after they've had the digital information, to then have that pre-assessment appointment remotely. Now, some people may ask for that to be face-to-face, and I think organizations should be able to provide it. But it's a real challenge. It's a workforce challenge. And maybe there is no fixed strategy that works. Maybe a blended approach is what we need. I think most clinicians and healthcare institutions are still figuring that out as we come to grips in the post-COVID era.
Yeah, and then probably it also comes to patient preference, right? So actually asking the patient, well, what do you prefer? And then actually just providing different options. And this also involves the patient already in this decision, what kind of e-consulting compared to face-to-face consultation is actually the right way for the individual patient. Another topic is digital divide. So everybody is talking about that, right? So e-consenting, e-information doesn't work if you do not have a laptop, if you do not have a mobile phone and things like this. Did you experience any problems with this topic, or did you actually see during COVID-19 that e-consultation and e-information is actually very possible at the moment?
Yeah, I think, again, it's another really important point. I think the infrastructure of having availability, the access to hardware devices and access to the high-speed internet, the Wi-Fi, there is variation across different countries, of course, and within countries across different demographics. And I think that's something really important, and something that we're probably not going to be able to solve this afternoon, and probably is a wider governmental issue. But certainly there needs to be support for a digital literacy program, I think, across different countries, because there are certainly groups of individuals who don't have access, who are probably left out by this process, which I think it's important that they're not. But what I would say is, I think that the older generation were really written off by a lot of people when COVID came about. And a lot of people said to me, they're not going to be able to use that because they're 80 and older people can't use tablets. And I don't think that could be further from the truth, because through this process, we trialed this in arrhythmia, particularly AF ablation, for example, because it's a very common procedure. As you know, this is something we tend to do in the older patient because of the prevalence of the disease. And I have to say, I was bowled over by the digital literacy of the population in general. I was really impressed with how people took to this very, very quickly. And even if individuals did have trouble and didn't have access or didn't have Wi-Fi and weren't quite adept with clicking on an HTML link, usually, not always, but usually they had a niece or a nephew or a relative that did. And the beauty of this is that they could do that with them, and the patient was part of and driving that process. So I think that it is possible. I don't think we should write people off and presume that certain groups can use it and certain groups can't. But I think there is a wider issue of pockets of individual being left behind. And I think that's something that we have to advocate for as physicians, and that we need to get local authorities and governments to help support in terms of infrastructure.
And just to follow on again a little bit from that, Jonathan, it seems to me that what you're describing here is a model that can be applied in a number of different ways. Because to me, it would seem that the information that you're providing to patients should be universal. This is a really good way to convey procedures, provided that you have a means of getting access to all your patients, to infographics, to videos of that sort. So that I would see as being universally beneficial. And then I suppose there is a process of tailoring, as you've just described, that consent process and the interaction process. And there will be patients who are quite happy to do that on a remote basis. But you're absolutely right. There are quite a significant number who will prefer that face-to-face interaction. I think it's also fair to say that from the perspective of a clinician, I think a lot of us feel reassured if we've had the opportunity to eyeball somebody back, if you like. And that, as Dominik's described, you build up a rapport with a patient that's very difficult to build up in the same way in a remote setting. So I think there is a model here that can have a number of different variants applied in different circumstances, different patients, but the fundamental principle has got to be correct. I think the maximum amount of information you give patients as part of the consent procedure, and the maximum amount of joint decision making, shared decision making that you achieve is all for the better. I think this is a really positive step forward.
I think it's interesting that you say that there need to be different models, and I think it'd be really interesting to know of other groups that have tried something similar, because I suspect that the way that we've done it was quite crude and simplistic at first, but there's definitely iterative steps that I'd like to take, and it'd be interesting to try a blended model, as we were discussing, and then get some feedback to actually see which one works best with different patients and different populations. But I suspect, as Dominik said, there probably isn't one hard and fixed rule, and we probably, as healthcare providers and hospitals, need to have the flexibility to offer that, and we haven't really had that in the past, let's face it, but maybe that's where we need to be in the future.
I'm sure that's right, and I think this is one of the things that has already been mentioned, that the pandemic has firmly kick-started. I can't see any of this having been achieved if we hadn't had to adapt in the way that we've had to over the last 18 months or so.
Perfect. Maybe actually one question what I also wondered about was, we also hear a lot about virtual reality techniques, right? And this is probably also something which can help some patients to already visit the operation room before the time actually that you get your ablation or your coronary angiogram. Do you think this might also even add another dimension to e-consenting, e-information, or do you think that actually the way how you used it, actually mainly information, figures, simple movies are actually the better way to go?
Yeah, I think the sky's the limit, I suppose, in terms of what's out there. That's for sure. We have already, as you said, virtual reality. We have a variety of platforms that enable surgeons to connect and operators to connect through Wi-Fi, and as you know, and jump in on a cath lab operation and share content and educational teachings and things like that. And there's no reason why that can't be made available for patients if they want it. I think the biggest challenge, though, is that there isn't really a hard and fast rule about what there should and shouldn't be, and we probably need to make sure we involve the patients in that process. I suspect that if you provided it to all patients, you'd probably scare quite a few of them off, because some people don't want to see that if you ask them. Some people will say, it's up to you, doc, whatever you think, and others will have 1,500 questions that they want to go through before they step foot in an operating room. So I think it can be really challenging, and I think our task is really difficult, because we have to try to keep the patients at the center, try to have something that's standardized, but yet have the flexibility to be able to provide information in a slightly different way if that's the way the patient wants to receive it.
Great.
Yeah.
Well,
congratulations. It's a very interesting piece of work, Jonathan. Really, really interesting. And it'll be equally interesting to see how it pans out over the next couple of years.
Thank you. And also, I guess it would be interesting just to ask you. I know I'm not really asking the questions, Simon, but to ask you with your hat as the Get It Right First Time initiative, which you were co-chairing and running within the UK. How do you see this process and others feeding into the sharing of information between hospitals? Can it be helpful, or should we be doing it like this on webinars?
So, I mean, I come back to, I suppose, to the principles of how do you provide the maximum amount of information to patients as part of the overall patient pathway. And if you can look at this on the basis of how that patient is progressing through a pathway, not just in one institution, but across a network, and heading to, say, the argument for ablation to the EP center of that network. And I think that this type of process, this type of tool, will facilitate that. And absolutely, I see this as part of something that networks may well want to take up in terms of improving the patient journey, avoiding unnecessary appointments, and actually to streamline pathways, get to the point where shared decision making can be accomplished in the most efficient way, with the minimum use of unnecessary resource that gets the patient to the treatment as quickly as possible. So absolutely, I think this will become part of the way that networks work in the future. And I think it will be very interesting to see how it is applied in that way over the next year or two, as the cardiac networks, certainly with England, start to mature and get to the point where they can look at this sort of technology and evaluate it. Now, I'm sure it will become embedded in clinical.
So I actually also get the feeling that this is really an addition to face-to-face consultations, and consenting, what we normally did until now. I think there are a lot of components which you actually described, which are related to patient information, patient consenting, having continuously the information actually available, and allowing the patient going through the material at a time point when the patient actually has a free mind to look at it, instead of being stressed in the hospital, in the outpatient clinic already, and actually having the physician sitting in front of them. This also creates sometimes a very stressful situation for some patients. And exactly like you said, Jonathan, probably a lot of patients just hear 20% of the things what we are actually telling them during a 15-minute consultation, for example. And we need to be aware of this. And I think there, particularly the continuous availability of information in this e-consenting, e-information setting might actually have a huge advantage in this. I think another advantage also of having a good e-consent and e-information system available is, of course, also the option of digital trials in the future. And also actually onboarding patients in trials is at the moment mainly focused on consenting information actually in hospitals, but also a good and proper e-consent, e-information approach can also, of course, help us in this setting to actually have larger studies with well-informed patients if this e-information and e-consenting approach is actually further developing. So I think that's a huge option for the future, and will provide a lot of opportunities for me. Okay, so I think if there are no further questions at the moment, so Jonathan, thank you very much for presenting this very interesting project actually which you set up in your hospital. And I think it actually shows that already available infrastructure can be implemented very, very quickly. You showed this actually during COVID-19 and can be used at the moment already. We are still learning, of course, which is the best patient, where the specific infrastructure can be used. We are actually seeing, and I really like that you actually mentioned this, that also older patients can use this, and that age is actually no exclusion criterion for e-consenting, e-information. This is also what we actually learn with mHealth at the moment, using apps and using wearables and using, like you said, e-consenting, e-information can be done by older patients. And this is what the patients actually show us. And we just need to understand better how to integrate this in daily practice and actually how to use it to make the information, the consenting of our patient better, and then potentially also even improving the outcomes of our patients. So thank you very much, Jonathan. Thanks.
Thank you.
Thanks, Jonathan. Thank you.